So thank you so much UPSOS and thank you so much AIOS for having me here. I'm going to talk about microinvasive glaucoma surgery, when and how. I don't have any financial interest. So according to the workshop of American Glaucoma Society and US FDA, MIGS was characterized by implantation of a surgical device or removal of tissue, especially trabecular meshwork, intended to lower intraocular pressure via an outflow mechanism with either an ab interno or ab externo approach associated with low or no scleral dissection. So why microinvasive glaucoma surgery? Because these are new bunch of options for all type of glaucoma with minimal tissue trauma. There are good and short postoperative visual recoveries there and can be combined with phacoemulsification. So it claims to revolutionize the glaucoma management because there is no conjunctival dissection and therefore no bleps, no wound modulation. IOP reduction is although lesser than trabeculectomy but at least 20%, and there is high risk of safety profile. So what are the indications of MIGS? It is mild to moderate primary open angle glaucoma, pigmentary glaucoma and pseudoexfoliative glaucomas. But then there are several contraindications like eyes with angle closure glaucoma, eyes with neovascularization, any hazy cornea or if there is anterior chamber and dysgenesis, and any patient with raised episcleral venous pressure like Sturge-Weber syndrome, and any type of advanced glaucomatous optic neuropathy. So when we classify this a microinvasive glaucoma surgery, there can be main 4 approaches of reducing intraocular pressure by MIGS. So first one is it increases the outflow across the trabecular meshwork through Schlemm's canal by bypassing the trabecular meshwork. It enhances the uveous scleral outflow by supragroidal space. It shunts the aqueous into the subconjunctival space and decreases the aqueous production by ciliary processes ablation. So these are variety of technique. So this is a classification of trabecular meshwork bypass which we are doing more commonly. So there can be placement of any stent like iStent inject, hydrus, or there can be tissue excision or tissue ablation like with Kahug dual blade, trabectome, GAT, ELT and ab interno canaloplasty. So I will be discussing more about Kahug dual blade and its other methods which we are doing at our center. So the Kahug dual blade goniotomy has been introduced by US in 2015, which is ab interno approach. Now here we can see this blade, which is a stainless steel disposable blade with dual blade having sharp tip, designed with taper or smooth entry through trabecular meshwork. If you see the heel of this particular blade here, it fits very easily in the Schlemm's canal for smooth advancement. And this is the ramp of the blade that actually has a dual cutting edge and creates a parallel cut into the trabecular meshwork. And therefore there is complete removal of trabecular meshwork and very little amount of surrounding tissue damage and therefore less of fibrosis. So here we can see this parallel excision of trabecular meshwork. But important thing are several prerequisites like neck mobility should be good. There should not be any tremors. Patient should be cooperative and angle should be visible in the clinic in your pre-operative evaluation. So here we need to position the patient nicely. We need to sit temporally, and what we need to do, we need to turn the patient heads to opposite side, and we need to tilt the microscope towards ourselves, and so that we have this kind of configuration. So here we can see this tilting where patient is tilting opposite and the microscope has been tilted towards us at 30 degrees. So this is the direct gonioscopy being done. Here we can visualize the nasal part of the trabecular meshwork. This is the KBD knife. And here we can see this is a sharp shaft which enters the anterior chamber after your phacoemulsification surgery. So this is the visualization of pigmented part of trabecular meshwork, and the heel rests nicely onto the surface of Schlemm's canal, and then we have to strip the trabecular meshwork. So once stripping is being done, we can see that small amount of blood, they start oozing out. We take a forceps and then strip the trabecular meshwork, and therefore the aqueous starts draining directly into the Schlemm's canal. So The efficacy has been proven to a wonderful levels of around 20%. It has shown comparable results with other device, and these are the several of the studies. Now, because this Kahuk dual blade is slightly costlier device, and therefore this modification of bent ab interno needle goniectomy has been done, commonly known as bang surgery, where we take this 26 gauge needle, we bend it just opposite to the capsulotomy, what we for our phacoemulsification. And again, similarly, we visualize with the help of direct gonioscope. Here you can see the trabecular meshwork nicely, and the scleral spur is also visible just beneath the trabecular meshwork. And here you can see stripping of the trabecular meshwork. Only thing is, because here the cut is slightly irregular, so chances of fibrosis is more often and more common in bang surgery. But because it is a very cheap the surgery to be done along with phacoemulsification, so nowadays people are doing it quite commonly. So these are our results. We found 20% reduction in our patients also, with a reduction in anti-glaucoma medications in our subset of patients. Although we had some complications like hyphema, but then it resolved very nicely. So these are the literature review for bang surgery. So to summarize, I would say that these new category of procedures, they have acceptable safety profile and humble efficacy. They, although unlikely to replace the traditional glaucoma surgery trabeculectomy, but then in mild to moderate glaucoma, to fill the void between the advanced glaucoma and these mild moderate glaucoma, it is a good amount of surgery, expanding the horizon of glaucoma surgeries. Thank you so much for your kind attention.
Very nice. Yeah.
Thank you, sir.
Thank you, ma'am. Thank you very much for this wonderful presentation.
Dr. Shalini, what is the percentage of hyphema in your cases?
What is the follow-up period? Do you think it's a primary procedure? It can be a primary procedure. Instead of going to trabeculectomy, you go for this one. We have to wait.